right. So, can hear us. Will somebody send me a message if you can hear us, please? Barbara. People are saying, yes, they can. All right. Good news, Marty. We are live. All right, everyone. Good evening. Welcome to Ask the Expert. Tonight's expert is Dr. Marty Levinson, who I can vouch for, as he and I have known each other for all of Benjamin's life. I met Marty when Ben was just 6 months old at our first convention in Cincinnati, Ohio, which was the Williams Syndrome Association's second convention. So we go back a long way. Marty has a practice in Beverly Hills, Michigan, not California. And where he sees, Marty, do you see all the adults, all the individuals, all the kids in Michigan, probably Southeast Michigan and part of Ohio? Almost a mini Williams syndrome clinic, I would say. Marty. Can you hear me, Mark?
Terry, I'm checking if I should be hearing you.
You should be hearing me. Everybody else can. And you and I could hear each other before. You can't hear me? Turn your audio back on again, Marty. Technical glitch here, everyone. Wait 1 second.
My mic is on, but
Okay,
I'm not
can you hear me?
hearing anything.
That's strange. We were hearing each other a minute ago. I could hear you fine when we first got on.
Okay, can you hear me now?
Yeah.
Through the phone or through the screen?
Through the phone and the screen. I could hear you. I can hear you all the time.
So I'm able if I talk on the phone?
No, probably not.
As long I'm not hearing anything.
Can you hear me now?
Yeah, possibly. They're hearing me, but I'm not hearing them. I'm getting some tech help here.
On Zoom.
All right.
It's not a Zoom. It's a.
But it would work. It was fine 10 minutes ago.
Yeah, it was fine when we talked before. Yep.
But you can hear them now, right? On the phone?
On the phone, but not through.
I'm going to hang up.
Okay. So she's hanging up.
Turn video off, turn audio off. Settings. There should be like an audio settings. That would go away.
Sometimes if you can't hear, Marty, you might want to go out and come back in.
Okay, now try speaking again.
Well, they're hearing me, but I'm not hearing them.
Okay. Your volume's up.
It's always something,
You might just. I wish this was Zoom because there's an option
Sure.
to call your phone.
How about if we reconnect?
Yeah, try that.
Terry, if you can hear me, I'm going to go off and then try to go back on and see what happens.
Perfect.
When I leave this, I just shut it out.
Okay, everyone. So Marty has left the room, but he's coming right back. Hopefully he'll be able to hear us this time. It seems like a few of you who have had to do this. I'm not sure why, except that I know that all systems are overcrowded right now. But as I was saying, for those of you who don't know, Dr. Levinson, wonderful pediatrician with 40 years experience, and as both on our professional advisory board and our board.
There we go. Terry, I hear you.
All right, good news.
Okay.
Okay, good. Well, Marty,
Reboot.
introduce yourself. I've introduced you, but take over.
The answer is always reboot.
Yes, exactly.
That's what that comes down to. Hi, everybody. This is Dr. Marty Levinson. I think I know a lot of you, but to those who don't know me,
Now you have frozen. I'm so sorry for this technical glitches here. I guess worst comes to worst, we'll all move over to Zoom. But hopefully we won't have to do that. Hopefully the third time is the charm, and when Marty comes back on, here he is now, it'll be great.
Terry?
Yeah.
Good. Okay. I disappeared. My computer said I had logged off. So I don't know what happened. So we'll just keep doing this. What I'm going to do is make a decision about the various questions. Some of the questions may be very, very specific and may not apply to a large number of people listening, in which case I will defer to a later time. Terry, if you can, my email address through this, or certainly you can go through the Williams Syndrome Association and get it. I'm happy to discuss this further in the next year or two if there's something that is just too esoteric to be of interest to the group in general. So with that, I think we're going to get started, and I'm going to move on. I'm going to move off to my slides. You can still see me, right, Terry?
Yes.
Okay, good, because I'm looking at slides. There was one question in particular actually came from Israel. I don't know if the person who sent it in is listening, but it's 4 a.m. in Israel, so let's jump into that one in case that person did decide to get up early and be on this webinar. The question is about a 7.5-year-old boy with Williams syndrome who is having there's some concerns about early sexual development. He had a bone age done recently that had a bone age of age 11, which means that even though he's 7.5, his bones are really more equivalent to that of an 11-year-old. So the question is it common in Williams syndrome, and is it to early sexual development? So earlier average onset of puberty is common in Williams syndrome. On the other hand, true precocious puberty, which is really extremely early and pathologic, is typically not seen. But starting puberty on the early side is, and if a 7.5-year-old has the bone age of an 11-year-old, you can assume they're going to start puberty earlier than other 7.5-year-old kids. The implications are really primarily for height growth, because we know that our kids are shorter than the average kids to begin with. If you look at the Williams curve, you know that the average size is smaller than the general population curve. If you're going to go through puberty early, you're going to have a growth spurt early, so you may start to speed up, but then when your growth plates close, you're going to stop growing at a younger age. So the predicted final age is going to be lower. So if you happen to be low on the Williams curve and are going through puberty quickly, then your final height is going to be shorter than expected. And that might be a reason to look to doing something to delay puberty. That's something that is done by a pediatric endocrinologist. It's done with medications. There's a variety of choices, but it should be decided on an individual basis. There's no automatic about it. So if it looks like the 7.5-year-old at age 12 is actually starting to show, or at age 8.5, is showing signs of pubertal development with changes down below, then there may very well be a good reason to consider slowing that down. And that's a decision an endocrinologist will make. So that's that question. Terry, do you want to go in order? Do you want to read the questions? What do you want to do?
Sure. Yeah, we can do that.
Okay.
All right. Well, let's go in order. This next one is about a 9-month-old child, Marty. Mom says her son never wants to sit with his legs extended, and whenever giving the chance, he pulls his knees up. He also doesn't like to be placed on his bottom. He always cries if she tries that. Then he'll deal with it and will sit and play for a little bit, but not for long. She would like to know if there's something that she should know medically about, an infant's legs and bottom for those with Williams syndrome. She just wondered if he never stops moving. Is bouncing making him feel better, like he must be in pain, or is there anything that, a test that she should have done or anything specific?
Got it. So there's separate components here. One of them is are the leg joints tight? And that's a possibility. Usually not at 9 months. That's unusual to be tight this early on, but you can have high muscle tone, especially in the lower extremities. And if that's the case, and if I took any of you and kept your knees bent for 2 weeks and then told you to go extend your leg, you wouldn't be able to straighten it all the way. Your knee joint would get tight. So if you spend most of your time with your joints being shortened, then they're going to be shorter. So it's like a vicious cycle. I think that a physical therapist should be able to help you with the actual stretching if indeed it's something that is tight and just needs stretching. The separate question is he moving around to make himself feel more comfortable? That's always a possibility. It doesn't suggest that something is seriously wrong unless he's irritable all the time. Kids in this age group, if they're irritable all the time, you have to look at their calcium levels and make sure it's not because that's out of whack. And that's a pretty simple blood test. Are they constipated, and is that making them irritable all the time? But it doesn't sound from the question, as I heard it, that this child is irritable all the time. He's just moving around all the time, which does describe a lot of kids with Williams syndrome. But the concern is, why can't he sit in a way that stretches his leg out? And that's something that should be very, it could be dealt with a physical therapist. And I think that it makes sense to see what the physical therapist says about it. If the physical therapist is unsure, then depending on where you live, you could look for a pediatric physiatrist. This is a doctor who does physical medicine and rehabilitation for children. And they are also in good training to tell you maybe he needs some kind of braces to actually provide some stretching for his leg. So it's not terribly worrisome. I can see that it's bothersome, but it should be addressed by a physical therapist to see, does he need to more aggressive physical therapy?
Great. Okay, this question is about a 3-year-old. She was recently diagnosed with pretty high blood pressure, although her heart has been extremely healthy. And parents understand that it is probably caused by some other area of her body and have scheduled a full workup of her kidneys. Blood and urine have all come back clear so far. And mom wonders what are the next steps if CT and ultrasound do or don't show something. You know, should they be worrying about mid-aortic or making sure that the docs are looking mid-aortic? Wondering if there is any recent developments in any of these areas or anything they should be doing that's related.
Okay, so high blood pressure we know is very common in the Williams population. Very high percentage of it. In a 3-year-old, not so common. So one of the questions is it truly high blood pressure, or does the kid just, go bananas every time you try to do something and the pressure shoots up? And that you sort of have to try to determine by getting the pressure done different times, maybe even different vicinities, different venues, and see what the blood pressure is. Now, if the blood pressure is truly high in a 3-year-old, you absolutely have to look at the kidneys. Some narrowing of the artery to the kidneys is seen in Williams syndrome, but it's not typically the reason why Williams kids and adults get high blood pressure. That seems to have to do with just stiffness of the arteries in general. But if there is a discrete narrowing of the artery going to the kidney, that's a fixable form of high blood pressure, fixable by surgery, but fixable. You would think that appropriate imaging by a specialist, if there's a kidney specialist and a cardiologist, they should be able to get to the root of that between CTs and ultrasounds. Mid-aortic stenoses, I don't think are terribly common at all, but I would think that the cardiologist on their own would want to look at the entire length of the aorta to be able to say, okay, well, this is not because of any narrowing that we can find anywhere. So I think that a cardiologist should be making that call. If the kidneys indeed are normal, if there's no narrowing of the kidney, the renal arteries, then it needs to be treated as high blood pressure because there are complications that happen if that gets untreated. So between those two people, a kidney doctor and a heart doctor, they should be able to get to the bottom of it.
Great. And if it ever is needed, there's a great mid-aortic syndrome clinic at Boston. Boston Children's, they are experts.
Good to know. Well, Boston is sort of the mecca for the heart stuff. That's true.
Yeah, exactly. This is a COVID-19 question, Marty. Can you please provide your opinion? Heightened risk for children with Williams, especially if they have cardiac or other issues. Are they at risk of having more severe side effects from COVID-19, especially in relation to their common heart problem, i.e. the severe inflammation syndrome that they're finding in the pediatric population that had the virus? And what are your thoughts in particular on sending children back to daycare?
Okay, good questions. There actually were several questions when I scanned them about coronavirus. And the reality of it is our kids are not more susceptible to coronavirus infection. There's nothing that points to that. Anybody who has an active heart problem that has not been fixed, that has high blood pressure, that has a stenosis that's significant, those people are at risk of complications if they get a COVID-19 infection. So we want to be extra careful with those individuals. But the Williams population in general, the only reason may be more prone, their tendency to want to run and hug people and expose themselves to a lot of people. But the syndrome itself does not make them more prone to it. So it totally, to me, depends on the cardiac pressure status, whether you need to be extra worried. I think everybody has to be worried about it. This multi-system immune reaction, the Kawasaki's like reaction to coronavirus is really quite uncommon when you look at across the board at all the cases. It's just very dramatic when it happens. It also is very amenable to treatment, by the way, if somebody recognizes it. So the doctor needs to recognize it, but I don't think that our population is more prone to have this complication. And this, by the way, doesn't happen with the infection. This happens generally 3 to 4 weeks after a coronavirus infection. So it's a post-infectious process that happens small percent of kids who get coronavirus infections. So yes, people should be aware of it and looking for, if you had an illness that sounds like, looks like positive coronavirus, then a month later, if you have a new fever or just really act sick, abdominal pain, sharp abdominal pain and vomiting seem to be associated with this. Then that obviously needs to be brought up to a healthcare professional with the information that they might have or probably had a coronavirus infection a month earlier, but not more prone to it. So again, I think if there's any in your mind, you should just ask your cardiologist based on my child's or even my adult child's cardiac status. Are they more at risk for complications if they get coronavirus? In terms of going to daycare, that's a tough one. We're dealing with this in my office. In Michigan, they just relaxed the rules starting next week, and day camps are opening, which frankly scares the bejeebies out of me because I'm not sure how they're going to keep social distancing with younger kids in day camps. And then the kids go home and who knows who they see and how many people they come in contact with. So, some people have to have help with their kids in order to make a living. And, we all take on risk. I mean, even when I get in the car in the morning to drive to work, I'm taking on a small amount of risk that something's going to happen to me on the way to the office. But it's a small enough risk that I don't think about it and I go to the office. In terms of going to daycare, if you have an option of skipping that, I would always opt towards being on the safer side, especially if my child has any underlying ongoing heart conditions, for sure, under those circumstances. I hope that answers the question for everybody. In terms of social distancing, I still think that we're not out of the woods and we have to do it. And again, in Michigan, there are parts of Michigan that have no coronavirus, but now we have people from the lower part that are traveling to the northern and western part. And I suspect that we're going to see more cases there because there're just going to be more people who are not being vigilant. And, the key with the masks, and please understand, the mask that you're wearing when you go out in public is not protecting you. It's protecting other people, which means that if you're around other people in close proximity and they're not wearing a mask, then you're not protected. That mask is not helping you. And you should avoid that situation. And this has nothing to do with Williams syndrome. This is what I tell everybody. This is what my family does. If you go into a store, they're not social distancing and they're not requiring masks, get out of there. It's not worth it. This is a bad disease that you want to avoid getting. Go for it.
Yeah, thanks, Marty. Let's move back to puberty, this time for girls.
Okay.
It's the youngest that you have seen girls start their menstrual cycle, and what is the recommended medication to stop the cycles?
Okay. So again, going back to the Williams population, puberty tends to come earlier than the regular population. True precocious puberty, these are girls that are 4 and 5 years old with significant development and starting to have pubic hair development. That is rare in Williams, but that must be treated. Okay. The question about the earlier puberty has some similar feel to it as the boys' question. If a girl starts, normal, if you look at what is normal, age 9 is the earliest that menstruation can begin and be considered potentially normal. And since breast development starts about 2 years before menstruation, then you figure that if you're getting breast tissue at age 7, you're going to start your periods around 9. So there's a practical component about being able to manage that. And then there is the height component. If your child is short already, they're going to be shorter than would be otherwise predicted. Again, this goes under the auspices of a pediatric endocrinologist. There are medications. Every time I get involved, I have to go back to the books and look it up because I don't prescribe these medications myself. But they're medications that have been tried and true. They've been used for a long time with success. So if it looks like your child is headed into a very early onset of menstruation and it's going to affect their height and it's going to affect their quality, talk to the endocrinologist and go over the pros and cons of going on the medication.
I think too, Marty, that we have a couple of great conference sessions by Dr. Takara Stanley, who's an endocrinologist out of Mass General, who talks a lot about Lupron shots and the other possible things that can be done for delaying puberty and when to stop, the treatment and all of that kind of stuff. So I would suggest anybody who has questions to look up the sessions from the past conventions to find the ones on endocrinology by Takara Stanley. If you
That's a great idea. She's an excellent speaker and she's really
right. And if you can't find it, just give me a holler. I can send you the PowerPoint if nothing else.
Brilliant. But again, this is not out of the realm of what a pediatric endocrinologist is going to be comfortable doing. They're not going to say, "Oh, this is too specialized for me." They know how to handle it.
Yeah. Great. Okay. This seems to be a 3-part question about a catheterization. 3 cardiologists have told this parent 3 different answers about the necessity of a cath. She's worried about the safety because her son has an allergy to the medicine, and it's hypertensive medicine apparently. And the doctor would like to start Lasix, but he has an allergy with sulfa. She's wondering what should she do? Blood pressure is 115/72, and also wondering. Says the physician wants to do a cath first, then surgery, which I think is pretty typical. What's the long-term benefit and disadvantage for surgery for kids with Williams syndrome?
Okay, so it's a bit complicated because I don't have all the information that I need to a totally legit answer. Let's go to the easiest question first. Lasix is not a problem if you have a sulfa allergy. Lasix is not a sulfa drug. It's a diuretic. It just makes rid of fluids, so you pee much more, but it's not a sulfa drug. So if your specialist is recommending Lasix, I would not hesitate to use it. In terms of the cath, listen, life is hard when you get 3 specialists telling you 3 different things. So if anything, as the pediatrician, if a patient came to me with that, I would say, I want to see the report from each of the doctors and understand what they're saying. In terms of surgery, I'm assuming you're talking about surgery for a heart problem. And if you are, it's important to lay a roadmap to that. And they generally will do a cath to do that. Now, the allergy, I'm wondering if you're talking about an allergy to the dyes that they use in the cath. That was what I sort of understood from the question. If that's the case, they get information from the cath without necessarily using the dye. Also, there's different dyes that can be used. Again, this is a specialty question. So I'm assuming that you're talking about pediatric cardiologists making these judgments and recommendations. You need somebody to sit down, maybe even call the doctors and say, okay, I'm getting 3 reports. Convince me why yours is right. And maybe you shouldn't be the parents, every doctor is going to make sense to them because they're going to give you their point of view and then you're going to say, okay, that makes sense. And then you go to plan B and that makes sense too. So maybe your pediatrician can act as the quarterback here and be in touch with your cardiologist to get a feel for why they're saying this. I understand why they would say yes cath or no cath. I mean, any procedure requiring sedation is a risky procedure. We know that. And therefore, I'm hoping that wherever you're talking about doing this is going to be in a specialty area that has appropriate pediatric cardiology trained anesthesia people If you're not, if you happen to live somewhere where you don't have access to that, then you're going to have to grin and bear it and go someplace that does have access to it, because you don't want to be doing a procedure like that on a complicated patient in a place that's not prepared to handle unexpected emergencies. And you sort of have to be saying, I need to go forward, presuming there's going to be an unexpected emergency. So I need to um, make sure that the right people are on board.
Great. This is about a 12-year-old. Her son has SVT and is going to be scheduled for an ablation pretty quick, as his episodes have been much more frequent. Is there anything she needs to know to get ready for the procedure or as follow-up?
Okay, so SVT basically means just bursts of very rapid heart rate, and it's a conductive problem. The electricity going through the heart is taking like a little U-turn somewhere and is causing the heart to speed up, oftentimes way, 150, 200 beats a minute. Now, this is not typically a Williams scenario, okay? On the other hand, SVT happens in human beings, and a human being can have Williams syndrome and have SVT. So an ablation is a procedure to find that little area that's giving the U-turn and just blotting it with electric current so it disappears, and then the heart beats normally. In the right hands, it's a very easy procedure. It sounds really complicated to me, but I've talked to people who do this, and they say we just find the spot. There are people who are super specialized in this, and we zap it. It's done, as far as I know, through through a catheterization process. So there's the same anesthesia risk that we all have. So again, in this case, I'm assuming that a procedure of this nature that would require a specialist to do the ablation would be done in a place that has appropriate anesthesia care. It still doesn't hurt to ask the question, will there be a cardiac anesthesiologist directly involved with the case before you go through it? Usually there's a pretty high success rate with this procedure. It's tolerated well. And again, it's not a Williams thing, so I don't want all the Williams parents to go, uh-oh, here's something else that I'm going to have to deal with. It's not terribly likely that you would. It's usually recognizable in an EKG. There's a pattern that the cardiologist sees in that, and they'll be able to tell you if that's what's happening. But again, this is not a typical Williams phenomenon. It should go fine. If it needs to be done because the heart rate just keeps racing, when the heart rate races like that, the heart doesn't function right. You don't feel well. And if you go through prolonged periods like that, you're going to have issues of heart failure. So it's got to be taken care of.
Right. This is from a parent of an adult who is partially paralyzed from the chest down. She is wondering, the young man was recently found to have bladder diverticulum, and he fights being catheterized, but the urologist feels that he's not urinating enough, and that really the catheters being capped is the best choice. So this parent is wondering what kind of treatment
Gotcha.
When that individual.
Okay. So I remember scanning this question, and I think that if I'm not mistaken, the paralysis was a complication of a previous surgery.
Yes, a spinal fusion that didn't work.
Okay. That's such a shame. I'm so sorry to hear that. You needed one more thing in the way, right? But listen, we deal with what we have to deal with. So I think you've got two components. Diverticuli of the bladder means there's a weakness in the wall and it sort of balloons out. Imagine the wall, that a weak part will just sort of pull out and you have like a second little balloon coming out of it. And it can be small or it can be large. Sometimes I had one patient where the diverticulum itself was larger than the bladder, and the diverticulum doesn't have any muscle in it. So when the bladder squeezes down to cause you to urinate, the diverticulum does not, so the urine stays there. I understand why the urologist says he wants him to empty his bladder more, but if he can't do it, and here the paralysis is contributing because the nerves that go to the muscles of the bladder have been affected in the same way. So, you've got like a double dose of a problem here. in my experience, there's no medication for bladder diverticuli. If they're small and not causing a problem, they can be left alone and just watched. There aren't many people who've had them operated on, but on the other hand, that one case I was telling you about was a patient of mine who, again, in his 30s, was catheterizing himself, and he learned to do it. He didn't like it, but he was doing it. But they finally found a urologist who was willing to do the surgery to remove the diverticulum, and it was a totally successful surgery.
Uh-oh. Marty's frozen again. This is bad news. You can hear us. You're frozen, Marty. Hopefully, Marty will be right back with us. The next question, can a child with Williams syndrome have Chiari malformation, type 1, and cerebral palsy? I know individuals with Williams who have Chiari malformation, also those who have cerebral palsy, and one who does have both. So the answer would be yes. If that is the question, it's very short, so I'm not sure if that's the exact question. But if you're just wondering if those three things can happen together, that answer is yes. I think Marty will be back with us in just a minute. You should sign right back on. Again, I apologize for these glitches.
I'm back. Are you there?
Yeah, you froze in the exact same position as the first time. It's very interesting.
Okay. Yeah, my computer just said I left the room. I turned around to see, and I didn't leave the room. I was still here, but
You're still...
insist
All right.
that I left the room. Okay, so we were talking. I don't know where I buzzed out, but I certainly can try to find out who that urologist is. But I think you need to also talk to a urologist about the fact that the quality of life in your son having to be catheterized is significantly impacted, that you want to look into the surgery. I think it's worth looking into at least.
Okay, next question. 6-year-old who has had rectal prolapse for a year. Physical therapy exercises have been minimally successful. Do you think surgery would be the best course at this point, or do they just wait it out? Some days he has the urge to go 4 or 6 times, some days normal, about 60% of the time. It was horrible when it first started, going to the bathroom every 15 minutes. It's definitely better now. But in general, had there been good outcomes with surgery or problems with reoccurrence? And if no surgery, what was the outcome?
Okay, so rectal prolapse is fairly common. I think it's about 10% of kids have it. And it means that when down to have a bowel movement, some of the rectum actually sort of pushes out. And you actually see it out there. It probably looks worse than what it actually is. I have never had a Williams patient who had surgery for this to my I've certainly seen it a lot, and it really goes away. You obviously control the stools from being too hard and control the pushing, okay, because it's a combination of that loose elastic tissue and straining with hard stools that pushes it out. If it's getting, which is what it sounds like it is, then I guess if it's not affecting the quality of life dramatically, I would be a little hesitant to jump on surgery. Surgery, again, should be successful. I'm sure there's a number that the surgeon can say that this percent of them come back. It's probably a small number, but I'm sure it's a real number. Again, the risk of surgery, anesthesia, if you can avoid it, if it's not a horrible and it's getting better, and you can keep the stools from being too hard and keep them from straining, then it should get better with time and completely go away. My son had it when he was younger, disappeared with just patience and using aggressive stool treatment. I'm assuming it's not bleeding and he's not having acute pain with it. That might change my mind about how to approach it. In terms of the actual surgery, what they do, I'm not honestly familiar with it. I think I've heard of a few different things that they can do. It's certainly worth a conversation with a pediatric surgeon to say, okay, what would you do? And what would I expect if you do this? And then say to yourself, okay, this still may get better. So can I live with this for the time being? You can always decide at a later time to do the surgery.
Great. The general guideline, Marty, how often should the child be seen by the pediatrician for routine checkups? He's 2 and has ongoing heart issues.
Okay. So first of all, if he has ongoing heart issues, then I'm being seen by a cardiologist. I think being seen by a cardiologist is a lifelong scenario. Even if you lucked out and you have significant heart problems, we know that some can develop at a later time. So being seen at least maybe every other year by a cardiologist makes total sense. And if he's followed by a cardiologist at age 2, he's being seen more often than that anyways. So normally at age 2, we're still seeing kids every 6 months, okay, up to 3. So we see children at 2, 2.5, and 3, and I would certainly do those. Beyond 3, we usually go to 4, and we do once a year. Now, if I have a child with significant problems, and that doesn't just mean Williams syndrome, but all kinds of things, I probably would continue to see them every 6 months just to review what they're doing, what kind of intervention they're doing, educationally what they're doing, could they be doing other things, etc. So I think that probably every 6 months with the general pediatrician, unless you find that the only problems you're having are the cardiac problems, and if the pediatrician is not particularly knowledgeable about dealing with special needs kids, well, if that's the case, you should find a pediatrician who's interested and knowledgeable about dealing with special needs kids. But I think that every up until 5 makes sense. And then from there, again, it depends on the situation, but usually we'll go to once a year at that point.
Right. Is it okay to give X-Lax regularly, or is it habit forming? Miralax and lactulose do not seem to be helping for her 10-year-old daughter. And the daughter also mentions fairly frequent belly aches between her chest and the belly button area.
Okay. So a couple things come up with this. Number one, I don't know that I've ever seen Miralax fail. The question is, was the dose pushed up high enough? Sometimes it just takes an inordinate dose more than what adults.
We lost him again. Marty, he has a bad connection. Once again, I am so sorry. Anybody has a WSA question that I can answer, feel free to throw it into the chat here. I'll be happy to answer. There is a question about can somebody? Yes, you may put a question in the chat when we will get to all the questions through the chat that we can in the time allotted. Perhaps we'll stay a little extra if folks are willing, since we've had to since Marty's had a trouble with his connection, has had to come and go so much. So for those of you who can be patient, yes, we can add on those extra questions.
We there?
We are there. What is with your connection? Jeez.
Well, I don't know. I seem to have good connections. Everything says it should be good, but obviously it's not. I don't know if moving to another part of the house makes sense. I'm currently in my that's my granddaughter's room, converted from one of my son's rooms because now she uses it when she sleeps over. But usually I do my telemedicine from this room and I don't have any problems. So I don't know. It looks like I can get back pretty quickly. So I think we were finishing the XLAX question. And again, I go back to the Miralax. And, every often something comes out about Miralax saying you can't use Miralax for too long. That is not true. Okay. I check this out, adult GI doctors and the pediatric GI doctors on a regular basis because I have a lot of patients, Williams and not Williams, who take Miralax every day. And it's a godsend for them. As a matter of fact, Josh has taken it every day for decades. And literally, if he misses a day, he pays a price for it. I do want to go back to one other thing. You mentioned the pain in the belly, chest, the belly button. That tends to suggest a reflux issue, which is very common in the Williams population. So I don't know if that patient has tried any anti-reflux medicine. How old was that one again, Terry? 12?
10?
10, okay.
10.
So, you could certainly try. So, they've taken Zantac because of a potential contaminant that causes cancer. There's no more Zantac, but there is Pepcid or famotidine, which is an acid blocker, and that can be bought over the counter and tried. And then there are these PPIs like Prilosec and Nexium and Prevacid, and those can be tried because if she's having pain in that part of her belly, I suspect it's not from the constipation, but that there's a component of reflux. And if that doesn't work, then she really needs to be scoped. Somebody needs to look in her esophagus and see what's going on there to her stomach. But I think that it's safe to try these other treatments. We usually try the Pepcid first, and if that doesn't work or works a little bit but not great, then you move on to the Prilosec or the Prevacid.
Okay. With the new role that the gut biome has in overall health and the significant medical issues those with Williams syndrome have with diverticulitis, diverticulosis, have there been any findings or measures that might help support a healthier gut biome and slow down the leaky gut syndrome that contributes to chronic inflammation?
Okay, so that's a very sophisticated question.
It's not your everyday mom.
Which I appreciate that. Biome is the normal germs that live in gut. The gut biome is very important, and we're learning more and more about it. And I see something new come across my desk every week about gut biome and impact on things. Now, there's no evidence that we know of gut biome is more of a problem in the Williams syndrome population than in else. This is where the use of probiotics has become very popular. It's become popularized in the lay community without a lot of scientific support. In general, I've always said I don't see any harm to using probiotics. On the other hand, I'm not sure that it does much, and I'm not sure that it's truly no harm. I've read some papers suggest, some probiotics can be harmful. Probiotic is basically you take a pill or a powder of something that's active bacteria that we call good bacteria, the kind that help our gut work properly. So one of the problems, if you think about it, is you look at these pills and it says, that, contains 1 million colonies of bacteria. And you go, oh, wow, that's a ton of colonies. That's got to do something. You're putting it into a giant vat. You're
Gone.
So really think about the numbers of how it gets diluted in the gut. The other thing is that this whole thing with leaky gut and inflammation, we don't know that that's a Williams thing. we know that it is likely contributory to some of the problems in autism, but I'm not familiar with any literature that suggests that a leaky gut is, when you think of leaky gut, you think of, you mentioned diverticulosis. Well, that's something big that you can see. It's a balloon out in a weak spot in the intestine. But leaky gut is referring to microscopic changes where the gut normally keeps things from being absorbed, and too much stuff gets absorbed through leaks in the in the cellular level between one cell and another cell. Again, I don't know that leaky gut is an issue with the Williams population. I have not seen any literature general use of probiotics in Williams population. Again, you're sort of on your own. I don't think that, it's one thing when you're taking an antibiotic for something and you know that it's killing off a lot of bacteria, that maybe at that scenario, taking a probiotic might be useful. But in general, I don't think there's data to support it yet. Now, that may very well change. There's a ton of research going on about the GI biome, all the way down to newborns. They talk about the fact that newborns who are born by C-section don't go through the vaginal canal. And one of the things that happens is they swallow from the vaginal canal, which is actually how we were designed to be. And that helps the gut work normally. And when you're born by C-section, you miss out on that. And your gut biome is different than babies who were born vaginally. So all kinds of research is being done about this. But as it applies to our Williams population, I don't think it does, not yet. A year from now, I may have a different report, but right now, that's what I can tell you.
Okay, great. Our son is 13 years old. Besides Williams syndrome, he has ADHD. It seems to have gotten worse during his teen years. We repetitively ask him to do something, and then he gets angry when we raise our voice. We have tried many medications, and literally nothing works. Our pediatrician stated, it seems like his body is immune to ADHD medication. Any advice would be greatly appreciated.
Sure, let's talk about it. So, first of all, technically, we're not allowed to say that a child with Williams syndrome has ADHD. And the reason is that ADHD is a term that refers to the behavior that you're all familiar with: the short attention span, the impulsivity, the inattention, the distractibility, that is not coming from any other known reason. But we know that ADHD behavior is very typical for the Williams population. So it's sort of a matter of, nomenclature, that a child with Williams syndrome behaves like an ADHD child in the respect of those core symptoms, but they don't truly have standard ADHD. Now, with that being said, there are some kids who respond nicely to typical stimulants, and there are some kids who don't respond nicely to them. To give a full answer, I'd need more information. There are a ton of ADHD drugs out there, and the most common ones we use are stimulants, and those are absolutely the first line that should be tried for the ADHD component that we see in Williams syndrome. So that basically is methylphenidate or Ritalin family, or your amphetamine family, and some kids respond better to one than another. And I've over the years that some doctors just have, I have one ADHD I use in this family, and I have one in that family, and if they don't work, then I'm done. Well, that's not how it goes, because even with the stimulant drugs, there are fine differences in terms of how they are released in the body and how they. So you do have to try different ones. The nice thing about the stimulants is you don't have to try them for a long time to know if it's working. You can usually tell once you started with one and you have an idea of what dose was psycho for your child, then switching to another one is very easy. You don't have to start at ground zero and work your way up. And usually the first day you hit the proper dose, you see the impact and you say, oh, this is good. Or you say this isn't doing anything, which means you need to push your dose up higher. And the dose has to be pushed until you either see an effect or you see a side effect that you don't like. If it doesn't do anything, it means you're underdosing. And some kids are very are rapid metabolizers, so that they just eat up the medicine when it goes in, and it takes a much higher dose. I mean, and this is true in all kids, not the Williams kids. I have some third graders taking higher doses of stimulant than a high school offensive guard who outweighs them by 200 pounds, and yet the smaller kid is taking a higher dose. So you have to individualize it. Now, with that being said, a stimulant's not going to be the answer for everybody. There are non-stimulants that are used for impulsivity. One of them is called intuitive, variable degree of success. The non-stimulants overall are not as successful as the stimulants, but for the individual child where they are successful, they're successful. Again, you have to have a proper expectation. So while a stimulant will tell you right away when you get to the right dose, a non-stimulant needs to be used for an extended period of time till you can draw conclusions we're on the right track or not. And it's very hard when you're dealing with this to have the patience to wait a month on a medication to decide whether it's helping or not. So again, I don't think that it's a question of a child being, I mean, they're either, if they don't respond to stimulants, we're trying to improve, I assume, their attention span, decrease their impulsivity, decrease the distractibility, so that when they do try to do something, whether it's online, in school, or whatever, they get more out of it. The whole idea of treating this is to allow them to get more out of everything we're trying to do for them. If your pediatrician doesn't really specialize in this, you should find someone who does, or you should find a child psychiatrist any child psychiatrist usually does, or sometimes there's some pediatric neurologists who do this. I found some pediatric neurologists just don't like doing this, and they'll defer the patients back to me for the management of those behaviors. But don't give up until you've really tried the whole gamut of what's out there. And again, I'm assuming you're trying it not just for your peace of mind, you're trying to make your child's quality of life better. And you should be doing that.
Great. Any thoughts on subaortic stenosis in Williams syndrome?
My thoughts are I don't know that much about it. Do you have a specific case in
No,
mind?
the question is just so used to hearing about problems above the valves.
Yeah.
Curious about that thin membrane below the valve.
Yeah. Again, this is cardiology territory.
Right.
So if there's a heart murmur that appears to be an aortic murmur, then you need to be under the care of a pediatric cardiologist. They will do the echoes and appropriate tests, and could do the right follow-up. But I don't know that I have any patients specifically with that issue, but I'm sure they exist. Obviously you can have aortic problems all the way along the aorta. You're very familiar with that, and then you have some even further down the path aorta, and that's again where you have basically renal artery stenosis is the equivalent of the same thing that happens in the aorta, in the SVAS, only it's happening way down at the renal artery that goes to the kidney. So these can happen anywhere. They can happen in the blood vessels going to the intestines and be a cause of severe intestinal pain. So that's one thing to be considered when you haven't found any other answer to stomach pains.
What do you suggest for a child who is, I don't know how old she is, her anxiety is such that she will ask 30 times a day what is going to happen next? They have a picture schedule for her, but it doesn't seem to be enough. How can parents help her cope with going with the flow, and that the anxiety that surrounds her of not knowing what's happening next? Sounds like a Chris McDougall question.
Yeah, well, that's something that I'm sure a lot of people in the who have kids with Williams have seen this,
Right.
And I've seen it as well in my own. So part of it depends on the age of the child and whether they're amenable to kind of cognitive treatment. So it depends on their overall cognitive level, whether they get anything out of working with a therapist specifically on that behavior to try to address how to change that kind of behavior, the anticipatory anxiety. When are we going to do this? When are we going to do that? So some kids are amenable, but some kids, it's just so pervasive, and they can't help it. And it's frustrating for you, and it's also frustrating for them because they can't help themselves. So this is a case where medication can be useful. Um, I would embark on an SSRI such as Zoloft or Luvox or even Prozac as a treatment for that. These are medications that have been used for a long time in kids. They're considered very safe. One of the drawbacks is it takes time. It may take 6 weeks of being on it till you see the effect. And if you don't see the effect, then you have to, bump the dose up little by patient to see the effect. But on the other hand, you're dealing with it on a daily basis, so you're going to keep dealing with it. If you think your child can work with a therapist to address the behavior directly, go for it. I'm never against trying to do therapy, but if your gut feeling is she's too young or she's just not going to get the hang of this, we're going to be spending our time and spinning our wheels, then absolutely think about the medication approach.
Okay, we have one more question of the ones that we received ahead of time. Daughter was diagnosed at Williams just a few months ago at age 2.5. She has already had open heart surgery to correct pulmonary stenosis and 3 different brain surgeries for hydrocephalus and Chiari malformation. The question is, now that she's been diagnosed with Williams syndrome, should parents also be, how concerned should they be about the possibility of other medical conditions typical of Williams, like kidney or gastrointestinal issues, calcium issues, etc. Although they haven't noticed any signs of that, they just wonder if they should be diligent any other way.
Right. So let's go back on this first of all. So, I mean, hydrocephalus is also that's where there's a blockage of the fluid that travels within the. It needs to be drained off. That's not a typical Williams syndrome finding either. It's not unheard of, but it's also not unheard of in the general population. The Chiari malformations is a kind of a brain malformation in the back of the brain, right where it's going out through the main opening in the skull to the cord comes out. This is not uncommon. I think it's something like 10%. Chiari malformations.
Yeah.
Let me see. I may even have that somewhere here. I pulled some stuff out. But regardless, the fact that you have a Chiari malformation does not mean it has to be fixed. This is something to be aware of. Sometimes it's an incidental finding. You're being investigated for something else, and they find a Chiari malformation.
Come back to us, Marty. Come back. Shoot, we lost him. I did see a question about the convention this summer. Somebody wanted to know if there was going to be any virtual sessions this July. There will be virtual sessions. They will not be in July. We're going to do them later in the fall, probably mid-September to early October. I'm feeling that many of you might be sort of virtualed out by July and want to get out in the sunshine and would like to respect that. But we definitely will be having, I would say, probably 2 weeks of sessions so that you would only have to do 1 or 2 a day. We'll spread it out, like I said, and we won't, of course, have all the 70 sessions that we had planned in July, but we will probably have 20 or so, maybe a few more than that. So stay tuned for information of that. For that, the one thing that we'll have in July, the virtual camp will be the end of July, the last week in July, and our virtual walk in Everywhere USA will be on August the 1st.
Okay. Again, with apologies. I hope you guys aren't hearing what comes out of my mouth every time I get
We are
kicked
not.
off.
We
Good.
we are
Shoot.
not.
Okay. Okay. We were talking about the Chiari malformation and the other things. So if the kidneys have been checked and they're okay, then they just need to be checked every 10 years. If the GI problem doesn't exist, it may pop up at a later time, but it doesn't exist. So you don't have to look for trouble. If your child is growing okay and not having symptoms in relation to the GI tract, then I think I wouldn't do. In other words, you don't have to see a GI doctor just because your child has Williams syndrome, as long as there's nothing else that's going on. I think it was about what GI and what else, kidney.
Yeah, just the general, calcium. Also, before
Yeah.
the child was diagnosed with Williams, the cardiologist just wanted to follow her yearly. Is that, you still think that's,
So for a 2-year-old,
yeah, 2.5, who had
yeah, no,
a repair.
yeah. Oh, it had a repair. Interesting. Let
Yeah.
me see if I have anything on that. I mean, to me, you let the cardiologist call the shots, but what did he say? Every other year?
No, every year,
Every
annually.
year. Yeah, I think that if they had surgery and it was fixed and they've been seen and stable, that should be fine if the cardiologist says so. I mean, listen, we're talking about a specialized person. We're talking about somebody, you had the surgery done, and following up the surgery, you have a cardiologist involved. I'm just going to see what they say on the official new. Yeah, it says, this is what it says, yearly up to age 5, so that's fine.
Great. Okay, so I just want to let everybody know we are now past, it's 10:08 Eastern time. There are several questions, Marty, in the chat. If you're willing to stick around, and if others are willing to stick around too, we can answer those.
Oh, yeah. Yeah, I'm good. I'm good till you kick me off again.
All right, then let's go and see if we can go down the list. What are your thoughts on taking collagen supplement for joint support?
I don't know that there's any data that really supports that that's useful. Again, I don't know anything bad about it, but I used to try it myself because when I got frustrated with my own joints. So I don't think it's a bad thing to try, but I've not come across literature that really supports making a difference. They have good ads on TV and they make lots of claims, but all these products, you look at what they say, and then there's always the fine print or the little disclaimer: this has not been approved, for the treatment or diagnosis of any problems. Again, trying it, not a problem. I'm always reasonable about trying alternative medication, as long as it doesn't sound, like it's coming way out of left field. But I've not found anything useful about it. No.
Okay. My son has vitamin D25 below the standard. Do you suggest taking D3?
So, presuming that his calcium is okay, you want to have normal calcium. You want to have normal levels. Now, the question is, what is below? Below is usually listed as less than 25. Most kids that I check are less than 25. They're like in the low 20s. I think if it's not below 15, then it's not crucial. But on the other hand, I try to have everybody have normal vitamin D levels. We live in Michigan, and I have all these people who say, well, now it's June, so my kid's outside, so I don't need vitamin D. That's not true. The kids need vitamin D. It seems like every month I read a new article about something good about what vitamin D does, totally unrelated to what I learned in medical school about what it does. We learned that it's strictly for calcium absorption and putting calcium into the bone, but it seems to have immune functions. We know that adults who have asthma have less problems with asthma when their vitamin D levels are higher. We know that studies far out of China show that people who had low vitamin D levels who got coronavirus had worse cases than people who had normal vitamin D levels. So the problem with vitamin D in our population is in making sure that it doesn't shoot their calcium too high. But if you can keep their vitamin D level in a normal range and their calcium doesn't go up, I think that taking vitamin D supplementation is fine. If you've never been on it and you say, okay, I'm going to start vitamin D, then after a month, check a calcium level and make sure it's okay. As long as the calcium stays in the normal range, then you want to have a decent vitamin D level. You don't have to be in the 40s. You can be like 26. That would be great.
Okay. 16-year-old daughter had a trivial mitral valve incompetency 4 years ago. Now has moderate mitral incompetency. And at what point will they replace the valve if it continues to worsen? They're seeing the cardiologist this month for follow-up, but mom is worried that the cardiac muscle will weaken and get damaged the longer it remains incompetent.
Right, right. So that's a concern. It's again, that's sort of a call for the cardiologist, but they're monitoring it, and it needs to be monitored, at least every year to see if it's getting worse. They sort of extrapolate and say, okay, this is what it was last year. This is what it is this year. There's a pattern here. If we extrapolate out another year of getting this much worse again, she's going to be in heart failure next year. So let's fix it now. If it's a little bit worse than before, but functionally she's doing fine, then they can just keep checking it and doing, echoes on it. I do suggest sometimes, and this is more invasive, and you can bring this up to the cardiologist, getting a special kind of echo called a transesophageal echo, TEE. It's a little more involved because with a regular echo, they just do it in their office and they lay down and they put it on the chest. This one, you have to be sedated and they put it into your esophagus so it looks at the heart from a different angle from behind it. And this can give more information, especially about the mitral valve. So you might want to ask the cardiologist at the next visit, depending on what they say about the regular echo, is it worth getting a transesophageal echo? And if they say no, then I would also tell them that there have been at least 2 cases that I know of, because one was my son, where all of a sudden that mild mitral valve prolapse basically went into floral mitral valve prolapse. One of the leaflets of the mitral valve just tore away from the heart, and he just went into heart failure and had to get a new valve the next day. And you'd rather avoid that scenario, and you should let the cardiologist know that even though this is not a common thing in Williams syndrome, it has been described in more than one case of someone with Williams syndrome where the mitral valve went suddenly bad. And if they're on the fence about replacing it, that might be the reason to do it. Now, obviously, you don't want to do that kind of heart surgery. This mitral valves are still not replaced, as far as I know, through robotic surgery going through the groin. Aortic valves are being replaced through just going through the groin and not doing open heart. Mitral valve surgery, to my knowledge, is still being done as open heart surgery, so it's a much bigger deal. On the other hand, if it's getting worse every year, you can justify doing it.
Right. My daughter was diagnosed at almost 6 with WS just a couple months ago. How common is a late diagnosis such as this, and how likely could we have missed major kidney or heart problems this late? Children's Hospital in Boston has been closed for months, so we have not been able to get a chance to do the tests. Nobody seems concerned. She's curious as to whether or not.
Okay, that's interesting. So it's hard to answer that first question. How often these days it tends not to get diagnosed that late anymore. 30 years ago, it was not uncommon. We even diagnosed some people. Even last year, I diagnosed someone who was 50.
73.
Yeah.
73 was the oldest.
So it does happen. But, I think it has to do with how significant her health problems have been, how significant her features are, and her developmental, cognitive profile have been, to make someone recognize it. Or maybe you just never saw a doctor that knew Williams syndrome and they said, this is an unusual looking child, but I don't know what it is. But it's irrelevant. You do need to have the kidney ultrasound. Now, I'm guessing they did some blood work that could be done to check kidney function. And if there's no murmur heard on exam and the child's been growing okay, then yes, you have to close the book and make sure a cardiologist sees them and get an echocardiogram, but you don't have to knock down their doors to get it done sooner if there's no heart murmur heard by the regular doctor who's taking care of her. On the other hand, I'm surprised that they're closed because, we're having, Michigan was hit pretty hard, but the specialists are back to seeing patients again, and outpatient procedures are being done, such as, echocardiograms and ultrasounds. So I would, try to be one of the first ones to do it just to get it over with. But they're right technically in saying that if she's 6 and there have been no problems with her blood pressure and nobody heard a heart murmur, it's likely that they're not going to find anything. They may find something that needs to be tracked down the road, but it's not likely they're going to find something that needs to be immediately taken care of.
Great. Okay, my son has struggled with hypercalcemia. He's now 1 year old. We're still having to very closely monitor calcium levels. Is this something that will be lifelong struggle, or does it resolve?
Okay, so the answer is in almost every case it resolves, which is mysterious because we don't know what causes it in the first place, and we also don't know why it resolves. Sometimes it comes back at a later time, usually from some different source, but I assume that he is being treated with the calcium restrictions in his diet and monitoring. And this is a kid you want to be careful and not give him too much vitamin D or extra vitamin D. The likelihood is very high that it's going to resolve. And I'm guessing that he's under the care of an endocrine doctor who's following him. If not, he should be. And I'm assuming that they've done an ultrasound of his kidneys to make sure there's no calcium deposits in his kidneys. I'm assuming that his blood pressure has been checked, and we know that that's okay. And if that's the case, then you just keep monitoring it, and one of these days you'll find that you don't need to treat it any further. I don't know if he's on medication or not. I don't think we said anything. Did they say anything about it or not?
No.
No. So, but again, that should be well managed by a pediatric endocrine doctor. And sometimes the kidney doctors will get involved with that too, but usually it's the endocrine doctor who does that.
Okay. I know feeding issues are common in babies with Williams. We have a 5-month-old who now weighs 10 pounds. He will take a bottle sometimes, but an NG tube has been placed. How long do you usually see babies keeping NG tubes in?
Okay. So that's very frustrating to have to deal with that. You'd much rather he learn to eat on his own. And I'm hoping that they're still trying to feed him something by bottle as opposed to just NG feeding. There's no good answer to that because it just varies from kid to kid. We know that a lot of kids in the first year of life suffer from failure to thrive. They don't gain weight. You track them and their weight drops way off from the expected weight. And we know why it's there because they're just not taking in enough. So sometimes they need to be on a more concentrated feeding so that the little bit they're eating is given a more bang for the buck. Sometimes you need that NG feeding just so that they're at least keeping up a reasonable rate of weight gain. If you follow the growth curve of most of these kids, you'll see that in the second year, they tend to get better. They start to eat better, and then they start to grow better. And a lot of these adults with Williams that you see who are really heavy set, you talk to the parents about what they were like in the first year of life, and you're going to get the same story, that they were very hard to feed. So you need to be patient. I wish I had a better answer to tell you, predicting how long that will be. One of the problems, if we're only feeding through an NG and he's not eating, then he's going to forget how to eat, or he's going to totally lose interest in eating. And then when we want to get to the point where he's hungry enough, he wants to eat, he won't know how to. And that's a big problem because they have to go through a big behavioral program. I would think you would want to get a feeding therapist, which in most parts of the country is an OT person who specializes in this, to evaluate what his suck is like, and is this like an oral motor skill problem, a coordination problem of how the mouth and tongue are working. The good news is it should get better. I can't look at anybody and say this is when it's going to get better, but it's going to get better.
Great. How often do you see celiac in Williams syndrome? This parent read an Italian study that showed a 10% risk of celiac. She's just wondering if that lines up with your personal experience.
So personally, I've seen less than 10%, and I look for it because it's been reported. But that's about what the report seems to say, about 10%. So celiac, usually you can screen for it with a blood test. And kids with celiac have stomach problems, stomach aches, which a lot of our kids have. They have trouble growing, which a lot of our kids have. But if they negative, then they don't have celiac. The official
Well, we have lost Marty again. I would say we've lost also about half of our audience. It's getting pretty late. It's 10:25. I think that we will end this here. I have all of the questions and I will be able to see them even afterwards so that we can reach out to those of you who have questions not answered yet and answer those questions for you. And again, I hope you got some answers this evening that helped, and certainly appreciate you tuning in and hope to see you next time. Thanks, everyone. Take care.